King, and I'm the Community Health Planner at King County Health Department. I would like to introduce Aida Palma Carpio. She's going to be doing our Spanish interpretation today. She's going to explain the next slide, so I'm going to hand it off to her.
Thank you, Stacy. And yes, if you can, yeah, that one. So I'll start in I'll just state that the event is bilingual. And so if you're an English speaker and would like to be able to hear whenever a Spanish speaker speaks in Spanish, but understood it in English, you'll have to also join the interpretation channel. And in order to do that, if you're on your computer, you'll look on the right-hand side, you'll see an interpretation globe. It's not active yet. Once we turn it on, you'll see that globe and that image down at the bottom right corner. And then you can select the language that you would like to listen to, which would be English in this case. If you're using your cell phone, you won't see the globe. You'll see 3 little dots at the bottom of your screen, and you can click on that to find the language interpretation option. And similar, you'll choose either English or Spanish. Y en español voy a comentar, este evento es bilingüe. Entonces va a haber interpretación en español durante todo el evento, y si están utilizando sus computadoras para poder escuchar la interpretación en español, van a buscar abajo de la pantalla en la esquina derecha un globito, como en la foto que está aquí a la derecha, y van a seleccionar la palabra español para poder escuchar la interpretación en español. Si están utilizando su celular, no van a ver el globito, van a hacer 3 puntitos abajo en su pantalla, como en la foto de la izquierda, y ahí le pueden hacer clic para encontrar la opción de Language Interpretation, dice en inglés, y le seleccionan ahí y después seleccionan la opción en español, así como está en la pantalla. And so once Stacy turns it on, people will be able to see these options pop up in your screen. I'll just add one note that let us know if you're on a Chromebook, because I believe that software has still not been updated to support this. So it would be good to give us a heads up. But otherwise, Stacy, let me just say that about the Chromebook in Spanish, and please go ahead and just start it. Entonces, okay. En español nada más voy a comentar que si están utilizando un Chromebook, a lo mejor tienen dificultades porque esa tecnología no ha estado actualizada para apoyar la interpretación, pero déjenos saber en el chat. Y van a aprender ahorita ya la interpretación.
Okay, I'm going to go ahead and start the interpretation. Okay, and then just a few housekeeping items that closed captioning is available. You can use the show caption button in your control bar to turn that on. Please remain on mute. You can place any questions you have in the chat, and we will monitor that throughout the presentation. There will be a question and answer session at the end of the presentations today. Next, I will introduce our panel of speakers. First, we have Michael Isaacson. Michael became Executive Director of the King County Health Department in June of this year. He has worked at the agency for the past 22 years and has had the opportunity to work on many exciting projects, including those that address behavioral health, chronic disease, early childhood and family support, emergency planning, opioid use reduction, and tobacco use prevention. Next, we have Patrick Stanley. Patrick is the program manager for community-based health promotion at the Rush University Medical Center Department of Social Work and Community Health, where he oversees multiple projects to bring evidence-based group interventions for chronic condition management, pain management, emotional wellness, and fall prevention to older adults throughout Chicago. He also oversees Rush Generation's social isolation initiatives and research. We also have Dr. Marissa Haff. In higher education for over 25 years, Marissa has worked students at the undergraduate, graduate, and doctoral level as they pursue their careers. She is currently an associate professor in the School of Social Work at Aurora University. She is also a clinical therapist at Gateway Psychological Services in Aurora. As a 20-plus-year hospice volunteer, she appreciates the unique story of each person and the need to support at the end of life. And finally, we have Kim Peterson. Early Childhood Program Supervisor and IRIS Community and Data Manager at Kane County Health Department. So thanks so much to all of our presenters today and being a part of our event. This presentation today is being brought to you by Kane Health Counts. Kane Health Counts is a collaboration of our 5 county hospitals, Advocate Sherman Hospital, Ascension Mercy, Ascension St. Joseph Elgin, Northwestern Medicine Del Nor, Rush Copley Medical Center, and the Inc. Mental Health Alliance. We also have a long list of community partners that participate in our health assessment process and bring so much to the table to our action teams in order to inform our planning and our work. So before we get started with our presentations, I do want to do a quick activity. So I'm going to drop a link in the chat, which I would like you to click on. I will say if you're joining from your computer and you have your phone handy, it might actually be easier to just scan that QR code that's on your screen. This is going to take you to menti.com or Mentimeter. So you can also go to menti.com and use the code that's provided on your screen. And what this is going to do is it's going to take you to a question that's being asked. What do you think are the main health needs in Kane County right now? And I've included on the screen some keywords. So you're able to input 3 words to use. So let those keywords that are on the screen guide you. I'm going to leave the screen up for just a few more minutes so everyone can use those keywords to input into the word cloud. So if you're not familiar with the word cloud, what's going to happen is the more times a word is entered, the bigger the word gets. So we're going to see what we can create here as everyone inputs their words. What I'm going to do is stop sharing this screen. And we're going to see here what is coming up. So it's really cool to see as the words come in. Again, the bigger the word, it means the more often people have inputted that word. So looks like mental health, substance abuse are some of the larger words. This is really cool. All right. Great. Well, I will share this word cloud again at the end, but let's see now how this compares with, oh, I have to. All right. Very cool. Okay, so I'm going to jump back to my presentation now. And we're going to look at how this compares then with what we did back in 2022 or 2020. Sorry, I just. All right, can you still see my screen or did I stop sharing?
You stopped sharing.
Okay. There we go. Sorry about that. Okay, here we go then. Okay, so sorry about that. For our prioritization results back in December of 2020, so almost 2 years ago, this is what it looked like. So we're seeing a lot of, again, that mental health is still at the top. Mental health was followed closely by access to health services. And then you can see how some of those other top health needs kind of ranked. back in 2020. So it looks like a lot of the health needs that were in the forefront 2 years ago are still on everyone's minds today, and are still an important part of our health assessment process. So once we did our prioritization and identified our top health needs, we were able to form 4 action teams to address these issues here locally. Those are behavioral health, which includes both mental health and substance use, access to health services, immunizations and infectious diseases, and nutrition, exercise, and weight, which we abbreviate to NEW. So those are our 4 action teams. And the teams have worked together to review the data gathered from our community health assessments and really took a health equity approach to their planning, identifying areas with the greatest need, looking at zip codes in our county that may lack resources, and recognizing those communities that may not have equitable access to resources or health services. So last year they began working to create implementation plans and have been working hard on those plans ever since. This cycle is a cycle that we do every 3 years with our Kane Health Counts partners. So that means in 2023, around this time next year, we will be doing another round of community health assessments and reaching out to our community for participation and input. You're welcome at the table to any of these action teams at any time, and we do hope that you will join us. You can join by visiting kanehealthcounts.org. The website is at the bottom of the screen here, and you can send information to be invited to one of those action teams. So we do hope you'll join us, and we hope that you'll also participate in the assessment process, as the collection of comprehensive data is so important. So with that, I'm going to hand it off to Michael to talk more about the data piece.
Excellent. Thank you so much. Appreciate it, Stacy. And thank you, everyone. Good afternoon. Thank you for joining us today for this conversation. Just want to share a little bit of information about what we're seeing in terms of issues with health equity, and then some potential opportunities that we have to work together to better assure that everyone in our community has an opportunity to be as healthy as they possibly can. So you may have seen a lot of different images that are used, different models to show social determinants of health and different factors that have an impact on equity in our community. This particular model is something that's being used as part of Healthy People 2030. And the key thing I want to just draw people's attention to is that our health is really influenced by a lot of different factors, right? So education is important, access to healthcare is important, economic stability, so meaning that we have an opportunity to have good jobs, that we have money to be able to afford housing and food, that we have an equitable distribution of resources in the community. And down at the bottom, you can see there's social and community context. And that's what we've selected to focus on today, is really that piece of equity and social determinants of health that really come from community, and how the connections that we have, or when people are isolated or don't have connections, how that really can have a tremendous impact on our health. So just starting with some basic information, who's in Kane County? We have just over 515,000 residents, and that's according to the latest census information. There's still some concern that the 2020 census may have undercounted some people in Kane County. So that's something just as I put out there as a little caveat. But using the current numbers, we have just over 500,000 people. Median household income is $83,000, which is a good average when you look across everybody that's pretty positive. And then the per capita income is $37,000. Looking at ages of people in our community, you can see that the largest age group is that 5 to 19-year-old. So we do have to be mindful. This is an important period of life where people are really developing habits and social connections that are going to impact their health throughout their lifespan. But also through this conversation, I want people to keep in mind that we have to keep in mind everybody's needs. So we're talking about equity. There's a lot of different aspects to each of us as individuals. So looking at this, we also have a community that's starting to get older. So compared to other Illinois counties, we're quite young, but that's slowly starting to change. So we need to make sure that we're providing services for our young ones, for expectant mothers, and we also need to make sure that we're making sure that the seniors who call Kane County home are getting everything that they need. Looking at race and ethnicity, there's a bar on the left side that looks at race. So you can see about 72% of people who live in Kane County identify as being white. Just under 6% of our friends and neighbors are Black. Under 1% are American Indian or Alaska Native. About just over 4 1/3 are Asian, and just under 0.4% are Native Hawaiian Pacific Islander. And you can see this group, the last two there, that are starting to grow. And this is something that as we do data analysis looking at demographics, we're trying to get better at this. But you can see some other race, 14% of people said they identified as some other race, and 3% of people identified as being 2 or more races. So we expect that over the coming years, we're going to continue to refine how we ask these questions. Over on the right, on the pie chart there, you can see ethnicity, where we're looking at who's Latino or non-Latino. And Kane County, of course, has a rich history of residents from Mexico and Central America, where 1/3 of our residents identify as being Hispanic or Latino. So that's something to keep in mind when we look at what the health needs of the population are as well. Looking at language, this is another area where we can see potential opportunities where we can do more to connect with people. So I'll just draw your attention to the red circle here. In Kane County, 68% of people speak only English, 26.4% speak Spanish, 1.8% speak an Asian or Pacific Island language, 3.5% speak Indo-European language, and then 0.2% say they speak another language. So looking at linguistic isolation, looking at what somebody's preferred language is, finding ways to connect with people in a way that's really meaningful to them, that's critical for all of our efforts. And I think you'll hear opportunities through this presentation for how we can continue that. This is some new data that's come out from the Illinois Youth Survey. So this is something that's conducted with middle schools and high schools across the state of Illinois. And we had about half of our schools participate. So with COVID, it slowed down a little bit, but 50% is not too bad. What I want to draw people's attention to, I already mentioned kind of the race and ethnicity, but looking at identification. So you can see between 1% and 3% of middle and high schoolers are identifying as gender or not male or female. So that's something important for us to consider and may bring, we see disparities in care and how people are treated. So we need to be mindful of that. And looking at sexual orientation, I find this pretty interesting that just about 3/4 identify as being heterosexual. And then between 3 and about 20% say that they're either gay or lesbian, bisexual, use some other term to describe their sexuality, or they're kind of questioning their sexuality. There's a small percentage of people who indicated they didn't understand the question, but that's something for us to keep in mind. We know there's different risks that people in the LGBT population run into. And we want to make sure that, again, when people are getting care and getting services, it's being provided to them in a way that is most beneficial to them. I want to talk for a second about something that's called the socioeconomic, socio needs index, rather. So we work with a company called Conduent that helps us with our data platform. So if you go to canehealthcounts.org, you can see all of our data there. And they have a proprietary kind of formula that they use where they look at income, poverty, unemployment, occupation, education, language spoken, etc. And they put these things together to try to identify, specifically looking at where people live. What's your risk? What are the chances that you're going to be healthy or not healthy? And when we look at Kane County using the Conduent Socio Needs Index, we can see that East Aurora, east side of Elgin, up by Carpentersville, that we have areas that on this map, the darker blue, show that people are more likely to be in higher need. So when we're talking about health equity, we know that there's a variety of things contributing there, but that frequently in public health, we talk about how your zip code is such a good predictor of your health that we know what's happening here is going to be important. Other things impact this as well. So just looking at income based on race. So these first blue graphs here are showing what the average income is by race. So you can see if you're white in King County, the average income for a household would be just under $90,000. For the African American population, significantly lower at $52,000. And we know what not only disparities, but also poverty, the impact that can have. Going over a few bars here, we see in the Latino population, 61,000 is the income, so quite a bit lower than if you look over here. This first green bar is the average for all of our residents, which is 82,000. So again, just looking at one measure, just income for households, we can see that there's disparities that may have a big impact on people's access to transportation, healthcare, et cetera. Looking at more gender and identity, this is some pretty alarming data that has come out through COVID, but this is looking at high school students, and this is national data that I'm showing here. High school students who say they feel persistent feelings of sadness or hopelessness. And unfortunately, over the last several years, we've seen a tremendous increase. Want to highlight that in our LGBT population, those young people are much more likely, where 75%, 3 out of 4 high school students surveyed in this particular study said that they felt persistent feelings of sadness or hopelessness if they identified as being LGBT. So you can imagine that just the tremendous weight of that. For our young females, over half presented and said that they felt those persistent feelings of sadness and hopelessness. So that's going to have a big impact as we talk about connectedness. We talk about things like social media and the negative impact that can have on what people's expectations are and how people treat each other on social media. I think that is really causing a lot of damage to our younger generation that we're going to need to address. Looking at an unequal distribution of suffering through the pandemic. This is one chart that stands out to us. This is Illinois state data. This bar on the left is the size of the population by race and ethnicity. So the orange is Hispanic. There's a really thin non-Hispanic American Indian Alaska Native line there. Asian is the red line, non-Hispanic Black is the green, and then gray is non-Hispanic white. So you can see vast majority of people in Illinois are non-Hispanic and they're white. When we look at the middle, that's who died from COVID. And so you can see we start to see some disparities there where more of our non-Hispanic Blacks were more likely to die. And then the graph over on the right, which really looks at connectedness and looks at the future, this is who lost a primary caregiver to COVID. And you can see that in our Hispanic and our African American population, they lost a much higher percentage. If you're one of those races or ethnicities, in Illinois, you're much more likely to have lost a primary caregiver to COVID, which is obviously that loss is going to have an impact on that person for the rest of their lives. This is a chart, and we'll share these with you, so I don't expect everybody to read everything, but just kind of the unequal distribution of pain as part of the COVID epidemic. So people may have had more jobs where they didn't have the ability to work from home. They had to be out there having contact with people, so it potentially puts them at more risk. We see distrust in health, and public health is something that's a problem in the country right now. Language issues certainly have impacted things. People may have struggled to get access to testing sites or access to treatment, or they were afraid to use public transportation just to be in close contact with other people who may have had COVID. And then the big thing we're talking about today, social isolation and just how connectedness has really been strained over the past couple of years, even though this is something in our country that for decades we've been kind of losing that connectedness across communities. So that's all bad news kind of that I'm sharing. So just want to talk about a couple of really positive things that we have going on that the health department's going to be launching. So number one, we're going to be forming community groups so that we can directly work with people. And so this is not a focus group to hear from a particular population. This is going to be ongoing efforts where we can have our residents participate. We'll share what we're seeing with the data, but then we want to hear from the public. What are the issues that are going on? What are the solutions that they see in their community? So when you talk about equity, it's always a problem where the quote unquote professionals show up from the outside, drop down and start telling people what needs to be done. We know that's not the most effective thing we can do. So over the next couple of weeks, we're going to be launching an opportunity for people to sign up to register to be part of these ongoing conversations with us to really drive what we're doing here at the Kane County Health Department. So stay tuned for more information on that. And then we're going to increase what we're doing with our partners. So specifically with children's mental health, we've had a group called WIDE, which is the Work Group for Inclusion, Diversity, and Equity. We're going to expand that beyond just children's mental health, and we're going to look at all health issues. But another piece that the health department's going to do is we're going to get better at using and sharing data. So if we don't know where the disparities exist, then we can't act on them to fix them. So we want to work with our community partners. We can learn from them. They can learn from us so that hopefully all of our programming and all of our interventions are going to get stronger. So again, over the next 2 weeks, we're going to be reaching out. As Stacy mentioned at the beginning, if anybody here would like to join one of our action teams that's already working, we'd love to have you. But there's also going to be other opportunities specifically looking at health equity coming up in the future. And with that, I'm happy to take questions. And Stacy, do you want to hold questions till the end? Is that your preference?
Yeah, that would be great.
Okay,
You can
very
put any
good.
questions
Thank
in the
you,
chat
everyone.
and we'll address those at the end. So next we'll go ahead and have Patrick start his presentation.
All right. Yes, I will go ahead and share my screen. Thank you so much, everyone, for having me. Can you hear me okay? Okay, hopefully there's where I'm at right now, there's a little bit of background noise, so hopefully that's okay. But we're gonna do the best we can, and I'm really excited to be here and honored that I was invited to share the work that we do at Rush around social connectedness. And so basically, I just wanted to talk about kind of social connectedness and social isolation kind of in this new normal of the pandemic and where we're at currently. And so again, my name is Patrick Stanley and I'm at Rush University Medical Center. So we do have Rush Copley Medical Center over in the King County area. But I am at the downtown Chicago location at Rush. So if you'll give me just a moment, I'm gonna do a little bit more noise cancellation so that potentially a little bit of that background noise doesn't come in. So essentially, social isolation is defined as the distancing of an individual both psychologically and physically, or both, from their network of desired or needed relationships with other persons. Therefore, social isolation is a loss of place within one's group or groups. And this is kind of the best definition that we found that really encompasses what we know social isolation to be out in the community, and really in the reality of social isolation, is that it's both psychological and physical. So the physical idea that you are not surrounded by other people, but then also that, you know, psychologically and socially, you're not connecting with other people, but that also that social isolation has an impact on an individual's psychological and physical well-being. And it's basically when they're disconnected from the relationships that are desired and needed. So essentially, that's really important to have that distinction as well, is that the quality of connection that people have. So if people are having connection really frequently, but it's very surface level, or with people who it's not like a valued connection or a quality connection, people can still be socially isolated or lonely. So therefore, it's really about your role within society and within your groups. It's a loss of that. So the primary risk factors for social isolation are living alone, having any sort of mobility or sensory impairment, major life transitions, socioeconomic status, so low income or limited resources, and I'll talk a little bit about that, about how that contributes to social isolation, being a caregiver for someone with a severe impairment, whether physical or mental, psychological or cognitive vulnerabilities, also location, such as being in a rural area, being in an unsafe area, or being inaccessible in an inaccessible location can also contribute to social isolation. For example, if you live on a third floor walk-up and you lose the ability to climb stairs, or you lose your balance, or you lose you lose that mobility, then you will become socially isolated if you live on that third floor walk-up. So, and then also in general, having a small social network or just an inadequate level of social support. Also having some sort of language other than the primary language that's spoken in the area where people live, that can also contribute to social isolation, as well as sexual orientation and gender identity, as it's shown that sexual orientation, sexual orientation, gender identity, and expression for the LGBTQ community is also places people, particularly older adults, at significantly higher risk of being socially isolated because of disconnection from social networks and disconnection from family networks as well. But I do have, before I go into a little bit more, there's a lot of different ideas about what causes social isolation and what our perception is versus what the reality is of what causes social isolation. So I actually have another Mentimeter here. So I'm glad that we've already introduced the concept of the Menti and the Mentimeter. So essentially you can go to menti.com and enter in the code 5838044, or use that QR code. And we just have one question. And then for those of you on the line in Spanish, feel free to also include your responses in Spanish, because I do speak both English and Spanish, so I'll be able to translate them for all of our English speakers here. So please feel free to type in the language that you feel comfortable if you're speaking Spanish. All right. So again, I'll leave that up for a second. Then I'll move us to our next thing. So what do you think causes social isolation? So what leads people to be socially isolated. And I think when we talk about social isolation, we're usually talking about older adults. But what causes people in general to be socially isolated? Not just older adults, but everyone. So we have anxiety, work, phones, aging, the lack of mobility, bias and misconceptions, lack of transportation, being bullied, lack of a network, loss, lack of finances, absolutely. The false sense of connection via social media, the pandemic, loss of a loved one, change, aging, lack of confidence. Definitely social skills are a really big contributor to social isolation as well. And that's one thing I do want to mention too, is that like we, in our social isolation initiatives, we also do social skills training, because oftentimes as people are socially isolated for long periods of time, that getting back into it and establishing friendships and establishing real relationships can be a huge, huge challenge for people. So we do social skills training in addition to that. So recent loss, remote work, fear of rejection, no longer being able to drive, the built environment, perceptions of differences within the people that are around you in a way that makes you feel unwelcome, too busy with work, depression, COVID, grief, fears, loss or lack of people who you can trust, fear of catching the flu, COVID, monkeypox, etc., change in health status, overworked. These are all amazing, that are right on the mark for what the actual causes are. Thank you so much for participating in that. That's really amazing. And yes, is right on the mark. So we don't have very many misconceptions about social isolation to bust while we are here. But good to know we're in great company. So, and then also, Stacy and everyone, if you could make sure I'm on time, that would be great too. I don't want to go over time at all, but do want to make sure we get to this. So in the midst of the COVID-19 pandemic, a lot of older adults have become more socially isolated than they were before because of long periods of social distancing and disconnection. Even with the prevalence of vaccines, as you all mentioned in the Mentimeter, there are a lot of people who, you know, even though they are fully vaccinated, are still fearful and hesitant to jump back into social engagement because of fear of those things. But it's actually, with all of us with the Omicron variant, even though we're fully vaccinated and boosted, still catching COVID is you know, well founded as well for people who really can't take it. Because I know I was double vaccinated and boosted and got COVID in the beginning of July, and it knocked me out for like 4 whole days. It was bad. So, but essentially those older adults who may not have been previously isolated may feel so now. And those who are already socially isolated have had their loneliness exacerbated by the pandemic. In fact, the Commonwealth Foundation found that amongst older adults in the United States, social isolation has jumped from 27% before the pandemic to 58% of older adults during the pandemic. We haven't done any study or data in 2022. Now that things are easing, but this data was done in early 2021. But reputable studies have shown that social isolation and loneliness can lead to more negative health impacts than obesity or even smoking 15 cigarettes a day. There is also a 45% increase in mortality of older adults who report feeling lonely. So in addition to the physical, and so also knowing that people who are socially isolated are significantly more likely to have a fall risk. So because fall risk has physical factors, but then also has socioeconomic factors and social isolation. So we did some data. It's a little bit outdated because the data was from 2013 to 2018 that showed that low-income communities of color had significantly higher rates of admissions and hospitalizations for fall-related incidents. And while there was no formal research completed on the root cause of the disparities, experts and anecdotal testimonials blame social and physical isolation, lack of access to healthcare, and lack of access to healthy activities due to limited safe outdoor spaces and food apartheid, also known as food deserts. So essentially, that fear of falling contributes us to begin socially isolating, and physically isolating. So essentially a fear of falling can lead to older adults beginning to restrict both their social and their physical activity. And the fear of falling can be pervasive and can lead to frailty and further social isolation. And many who are already socially isolated and or frail may have gotten to this point because of a fear of falling or because of mobility issues. But there are a number of barriers that hinder older adults from the opportunities to socialize. And this is actually from the Care More Togetherness program in California, which is a friendly caller program specifically for people with social isolation and loneliness. And these were the top issues that were identified amongst their patients. That were medical issues, pain, depression, transportation, and grief and loss. So also, I want to talk for the rest of the time about what we can do to address social isolation and loneliness. So this was actually an article that Russia's Friendly Caller program was featured in back in April 2021 that showed the impact of our Friendly Caller program, and actually did an interview of one of our friendly callers with one of her call recipients and the major impact that it had on her feelings of social isolation and loneliness during the pandemic. And I'd like to put the link to that in the chat so you can watch it on your own time, but it is kind of a long video, so I don't want to take the time of showing it now. I really want to encourage you to watch that later and really see it's so touching, and it's really shows the impact that these social isolation initiatives can have on older adults. But also keeping in mind that, like, while I'm talking about these social isolation initiatives, it is not going to be easy for anyone to implement these. Social isolation initiatives require us to reach out to older adults, and older adults are significantly more susceptible to frauds and scams. And unfortunately, these people who do these frauds and scams prey specifically on older adults who are socially isolated and lonely, which is incredibly awful. So it's normal for older adults to be apprehensive to engage. Older adults have been targeted more than ever since the COVID-19 pandemic for frauds and scams. The Federal Trade Commission estimates that US older adults have lost at least $602 million to fraud and scams and financial exploitation schemes, and an additional $100 million to COVID-related fraud. So one of the things we do is the Friendly Caller program. And so essentially we do friendly calls rather than more structured calls with screenings, because through the Care More Togetherness program, so other friendly caller programs who have come before us, we've learned that those who received friendly calls had fewer referrals made, but their social isolation scores improved significantly. But those who received more structured calls with more screenings by social workers or community health workers, they did have more referrals made, but their social isolation scores stayed relatively the same. So that's why we do friendly calls and not screening. So friendly calls, people have said, I felt special because this person was volunteering their time to talk to me with no other agenda. And I look forward to the calls every week. It's great to have someone that I can talk to about anything. And they genuinely care about how I'm doing. Whereas the more screening-based calls said they really appreciate it, but they could really tell that they were still obligated to call them. I already have a social worker, or it was a lot of questions and I don't feel comfortable getting out my information. So that's how we do that. Essentially, there's some potential solutions identified through some of our national experts that are on an individual level, a programmatic level, and a structural level. Individual levels, basically we want people to spend time with loved ones and schedule time each day to stay in touch with their family, friends, and neighbors. Practice assertiveness doing that. Find a new activity that brings you joy, and even better if you can do it as part of a group, like joining a walking or exercise group or class, or getting involved in your community and volunteering. And there's so many activities through the different park districts that you can get into. Programmatic levels, we can do friendly caller programs, friendly visitor programs, congregate meal programs, intergenerational programs and opportunities, making sure that in our organizations and hospital systems that we are screening for social isolation and loneliness, and providing opportunities for socialization, such as groups and activities. And that structurally, we need to widen the lens beyond seniors. social isolation does not just affect older adults, but it affects everyone. And if we stigmatize it by just attributing it to aging, then people may be less likely to get involved. But also, as we talked about earlier, inequity is the root cause of social isolation. Also, understanding the difference between social isolation and loneliness is really important for addressing it. And also on a structural level, we should be advocating for more funding for programs that provide engagement. So essentially, I wanted to put out here that a lot of the groups that we're doing through the Rush Generations program are really helping to address social isolation, including our friendly caller programs, but also our walking groups and our other groups that we do, support groups and groups to help people better manage their health and their fall risk. So it really just, getting involved in a group is something that I cannot overestimate how impactful it is to people and their feelings of social engagement. So I really, really want to encourage that. And that's something that Rush Copley is really moving forward with us doing more of these groups for older adults. So that is it. If you have any questions or want to collaborate or discuss more, please feel free to reach out to me by email or phone, preferably email. And then here's the information from my organization and department. Would welcome any questions or discussion if time allows.
Thank you so much, Patrick. Yeah, and I just a reminder, you can drop questions in the chat. We're going to continue on with our next presenter, which is Dr. Marissa Happ.
Hello, all. Well, before I start, I just have to say, Patrick, I'm so impressed with those programs. You know, the social isolation, meeting them at that level, very powerful. And the walking groups get some cardiovascular exercise in there too. And, you know, the outcomes are manifold. So I just really have to give you so much credit. Well, hello all. I think we can all agree on the fact that when we look at the needs of our community and, you know, broader scale, we all agree that diversity, equity, and inclusion are of enormous importance. We all agree on that. We also agree that meeting the needs as they present themselves to us are enormously important too. As social workers, we kind of look at the macro level where we have policy, and we look at the meso level where we have organizations, and then we look at the micro level where we have individual approach to the needs that we see around us. And those kind of correspond very nicely with what Patrick was talking about at the structural, the programmatic level, and the individual level. So in social work, we have something called the grand challenges. They identify 13 areas of need and the commitment to address those areas. Now, granted, we are talking about large-scale policy changes that need to happen. And so at the structural level, changes need to happen. We're also looking at the meso level. How can organizations bring forth change so that programmatic level, that meso level. But I think the common question that arises is, what can we do as individuals if we are not involved at the policy level, or we may not even be involved at the organizational level? Are there ways we can impact our community individually? And I think as social workers and as human persons, I think we know the answer is yes. So what I want to share with you is a set of slides looking at what those grand challenges are. And yes, there is a slide that gives you a statistical fact about each one of them. That's not the big point here. The point is, I would like to paint a thumbnail sketch of individuals of whom I am aware have reached out on that micro individual level to meet maybe a very obscure need. And I will share my screen with you. All right. Can you see the screen? All right. So the first one is looking at the individual and family well-being. The first one in that category is to ensure healthy development for youth. That's a no-brainer. Of course, we all agree with that. We know that children who are immigrants, people who have come to this country for any number of reasons, have higher rates of trauma. And healthcare accessibility can be very challenging. I'd like to tell you about a social worker who was working in a behavioral health hospital, and a small young girl from Guatemala was admitted. At the time of her admission, for safety reasons, she had to give up her worry doll. It was not allowed because there is wire, there are, little wooden sticks. And it was a real issue. The social worker very creatively had a session with her and said, I know you really rely on this worry doll. And right now, while you're here on our unit, it's not something that you can have in your hand, but we're holding it for you and you will get it when you get discharged. But how about till then? How about I become your worry doll? And how about everything that you would have said to your worry doll at night before you put it under your pillow? How about you say those things to me? And that social worker changed out of her business casual of gray and black and began dressing in vibrant colors, accessorizing with sashes, to make that little girl feel like she had become an embodied worry doll. The next one is closing the health gap. We know that COVID impacted this, and we also know that supplies ran very low, to put it mildly. I am thinking of the human person who noticed her neighborhood social media. Somebody had posted, this would have been March or April of 2020, that this person was experiencing symptoms, did not have a thermometer, and every pharmacy within 25 miles was out of thermometers. This person hopped on the social media and said, I have an extra one in the package. Give me your address. I will jog it over to your house. We will not have physical contact. I will leave it on your front step. This is curbside delivery with my deepest hope for your wellness. Build healthy relationships to end violence. We know that family stress is an enormous contributor to domestic violence, child neglect, and abuse. I am thinking of the person who at 2 a.m. on a hot summer night with windows open, heard the next door neighbor's toddler wailing. Already it was known that this little toddler was teething. And he said to his wife, you know what? I know it's 2 a.m, but I'm gonna go, we've got popsicles in our freezer, and I'm just gonna take one over because I know that that's gonna help, let's call him Charlie. It's gonna help Charlie's gums. So Dad marched over this popsicle, 2 a.m. And that neighborhood friendship took on an altogether different tone. after that very simple encounter at 2 a.m. Individual and family well-being. Goal is to advance long and productive lives. We have already determined that aging populations are at risk for social isolation, loneliness. There is all sorts of ambiguous loss that is being faced. I am thinking about the person from the Fox Valley area who traveled back to her hometown about 40 minutes away from here for her daughter's soccer tournament and thought she would just drop in to see if her next door neighbors from her childhood were by any chance still alive. They were in their 90s. They very cautiously opened the curtain, threw open the door, and a 2-year weekly relationship began that went through the death of the elderly woman and continued until the death of her husband as well. 2 years, weekly visits, pro bono, and listen to all of this person's life review. Eradicate social isolation. We know that COVID, again, specifically, caused a lot of social isolation. And this is a picture of my neighbor. He happens to be a music teacher. And in the midst of COVID, when our 84-year-old neighbor was not able to travel to visit her children and grandchildren, nor were they able to come to visit her, he gave nightly concerts on his front step with hat and gloves so that she would not feel isolated. And every night she was at her window with the windows open so she could hear the music. In fact, the whole neighborhood was. And homelessness. We know that homeless populations feel lonely, and in a nutshell, the thought is, what would happen if we treated people who do not have homes if we treated them as we would like to be treated as human beings with value? This one is a social worker. When J.C. Penney put a special deal out there on sterling silver, tiny, tiny, tiny 1/10 of a carat diamond rings, this social worker said, you know what, I got a bonus. I'm going to spend my entire bonus on as many rings as I can buy. And I'm going to carry one at a time around in my car. And I will know who and when I should give these away. A new way to think about your bonuses, right? Creating social responses to a changing environment. Especially in the light of this most recent devastating Hurricane Irma in Florida, but certainly it's not the first natural disaster and it won't be the last. I'm thinking of another social worker who, with every paycheck, buys a pair of shoes on clearance, stacks them until she can donate them to the Red Cross in bulk to be brought to people who are experiencing natural disasters. Harness technology for social good. Well, we've all become pros at that. And frankly, if there is any silver lining at all to COVID, I think it is what it has enabled us to do with technology, because without it, many things would have shut down. You notice I'm not reading all of the stats. I don't think that that is so much what matters here. But this is one of our instructors. When all of our classes went remote at Aurora University, we had all of our students on the screen. And by the way, for confidentiality, these are not our students. I grabbed this picture off the internet, but this is what we did. And one student in one class was expecting a baby in the midst of COVID. So the professor decided to throw a virtual baby shower. All of the students sent in letters of affirmation, and then the instructor put together a gift basket and had it delivered to the home. And a good time was had by all. Can you see a threaded theme in all of this? In each case, on a very small level, it's building community, just society, to eliminate racism. We know the dreadful reality of police brutality. We also know that law enforcement is beginning to realize the importance of mental health awareness and how to treat human persons in general. 1 week after George Floyd died, a white middle-aged male reported to me that exiting the expressway, he had been rear-ended by another middle-aged male who was Black. They both pulled over. The Caucasian male was prepared to, exchange information on insurance, make a report, et cetera, et cetera. The Black man said, "Could we handle this outside of making a call?" And he took out his wallet and he said, "I will pay you whatever you think it's going to take to fix your car. Name it, name it." And the man who had been hit said he had to think very quickly. And what he decided was in a flash. And in a flash, he said, "Yeah, sure, yeah. No, we didn't have to make a call. Here's what we should do. This isn't bad. We're both okay. How about we both get back into our cars and let's both go where we were going?" And the other man said, "How much do you need?" And he said, No, I don't need anything. No. They shook hands. The man who was white reported to me, who was telling the story, said, "I don't know if I did the right thing or the wrong thing. I don't know. But at the moment, I just knew what I thought I needed to do. And I can drive around with a dented car. It suddenly didn't seem that important to me." Promote smart decarceration. We know that youth in our juvenile justice system have experienced the majority of them, any numbers of trauma. We have a social worker up at Fox Valley Hands of Hope that said, "What about all of these kids just a couple miles from here? Perhaps we could take our grief groups, our support in there on a regular basis and develop relationships with these young people." That is the birth of a new program. It's what they do. Build financial capability and assets for all. Looking at people who are incarcerated, many find upon release that there are skills that they need if they are going to be successfully able to move forward with their lives. We have an MSW grad who also obtained his MBA. And he took a position with Cook County Sheriff and decided that he could put together a program about financial skills, and he began offering it on a weekly basis. He wrote the entire program and thought that that could be a valuable contribution to the population he was working with. reduce extreme economic inequity. 1 in 3 college students faces food insecurity. At Aurora University, we have a food pantry, and it's called Libby's Place, and students can come there for whatever they need. We also have the Spartan Attic, where students who are getting ready to go out on job interviews can come and get professional clothing. All of this at no cost, all of this no questions asked. The last one, achieve equal opportunity and justice. And if you want to apply that for healthcare, we know that to this day, equity is not a reality for many people, nor has it ever been. And I guess I will just give a shout out to VNA Healthcare, which started over 100 years ago with a small little handful of women and men who decided they wanted to address the healthcare needs in this area. We had the flu epidemic going on. We had diphtheria and typhus, and they decided that they wanted to change how healthcare could be delivered by bringing healthcare services to the most vulnerable. And today, they have expanded exponentially. And now it's our turn to act. Okay.
Thank you, Dr. Happ. That's great. Our next presenter is Kim Peterson, and Kim is going to talk to us about our IRIS system.
Yes. Hi, everybody. Kim Peterson, like Stacy said, that was a very powerful presentation, and also Patrick's. And the whole time I was thinking, you know, I'm also a social work brain, psychology brain, and not only relating to all of the stories, but just thinking about these concepts and these, you know, it's easy to kind of say like, do all these things, but how? How do we start? And what we focus on here at the health department are system level improvements, because our systems, you know, are the things that can either have the power to keep folks down or to raise them up. And it's really hard to get everybody to work together on that systemic level and come together in action to complete some of these things that were mentioned. And I really loved what she was saying about tech for social good. And I was like, oh, well, IRIS is tech for social good. You know, we're using what we are able to do today in tech and using that to implement more supportive services. And we talk a lot about isolation, and the opposite of isolation is connection. And IRIS also helps with connection, makes it more efficient, makes it easier, reduces stigma. And it helps with equitable access to services. The more you know, the more you know. The more the providers in the area, despite the rapid turnover, despite our staff shortages, the more continuity of care that we can provide in our community, the more equitable things will be in process, and then therefore expanding access to all the wonderful services we have in this area. We're a service rich area with a lot of passionate providers. And so, you know, this tool has really provided our community a way to kind of like flex that we all work together, and that we're really, we have a lot of services. And I will show you kind of what we've done with this and how we can, what we're going to be doing in the future. So let me just bring the presentation up, and we will talk specifically about IRIS. So the IRIS system is a system that was created by the University of Kansas Center for Public Partnerships and Research. It's now in over 23 communities here in Illinois. Each community approaches it with a different approach, basically, and we'll go into how we do it in a second. The first thing I'm going to do, most of you guys are familiar with Iris, but I'm just going to show a 1-minute video about the tech, you know, the overall, what it looks like, what it was designed for, and then we'll go over, you know, the stats from our community. Give me a thumbs up if you can hear it. No? Hold on one second.
You may need to
Hopefully.
choose in the sharing to share or optimize for video. So reshare your screen and there will be 2 check boxes that say optimize for video. and
Okay, well,
include
let me try
audio.
this really quick.
Iris is a web-based communication tool that helps organizations connect families to the right resources in their community. Iris helps coordinate services for families by linking your community's service agencies and organizations with a shared communication tool. Iris is simple, mobile, and customizable. Here's how it works. A family's information is entered into our HIPAA-compliant system. A partner agency is selected and the referral is sent. As referrals are rejected, accepted, and completed, both referring and partner agencies are kept in the loop through email notifications. Organizations can indicate their own capacity, allowing referring agencies to make informed choices. Families are provided with a clear path between different community services and are connected to the services that meet their needs. Providers save time through streamlined communications and can efficiently track all the referrals in one place. Communities gain a wealth of information to help drive data-driven decision-making and guide resource allocation. Iris, helping families thrive through connected communities. Contact us today to discuss.
Okay, so that's just a really quick little synopsis of what the tool
Your needs
can do.
and to see if Iris is a fit.
Now, let me go back to the presentation. Can you guys see the presentation now? Yes, okay. So when we started this, we started the groundwork in 2019, just kind of polling providers about the referral process currently, what people were doing, if they had the want or need for a better, more efficient process, of what their barriers were. And people were saying they're still doing, you know, a mix of like Post-it notes, email, voicemail, texting, things that, you know, and then there were HIPAA concerns and all of these kinds of things. So it just wasn't efficient and it wasn't being tracked to the point where, you know, we could all compile this information to look at where are gaps in services, where is the greatest need, things that would help drive funders to fund the appropriate areas that have the highest need. So our vision when we started was that the King County Iris community will build upon a strong collaborative relationships with partners to implement a data-driven, comprehensive, closed-loop referral system that identifies gaps in resources so that community members will be more efficiently connected with the services they need to support positive outcomes. Now that's wordy, but you get the point. We really wanted to have that support and make it efficient and also make it easier for our providers. We're all under stress, we're all overworked, and the staff shortages have not helped that. So it helps on both ends, our community members as well as our staff. In our story, I'm not going to read this, but again, we started back in 2019. We gathered over 80 community partners and talked about standards of use. We set up our filters in the system and made sure that we all kind of agreed upon how we were going to do this, a true collaborative system improvement effort. As you can see, I don't have much time, so I'm going to be going through this quick, but the growth that we've experienced has been great. In March 2021, we launched with 66 community organizations and of course, 0 referrals at launch. And then moved forward 1 year to March 2022, and we had 110 community organizations and 1,512 referrals by that point. Now that means that was, you know, connecting individuals and families with the services they need 1,512 times. Okay, so, you know, again, this is a new system, this is a new process, and really everyone took off with that. and really used it. And we were seeing great results. Now, fast forward to today, I just pulled this data and we're preparing for our year 2, quarter 2 meeting that everyone is welcome to attend. We now have 147 community organizations. That includes schools, mental health organizations, substance use, like Dr. Happ was saying, financial empowerment resources, and healthcare, you name it. You can pro-social activities, mentoring, we have it all. And most of the services involved are free, reduced costs, offer sliding fee scales, and or accept Medicaid. And we are currently up to 3,457 connections at this point. So it's been great. The progress has been actually phenomenal when you look at this large group of people adapting a new process to make our community stronger. And then some of the user feedback that we received from our partners at our annual meeting when we do this big survey are around ease of use, efficient workflows, and then partner communication. So folks were saying they love how easy the system is to use and the transparency of the follow-up. You know always like what is happening with the referral due to the technology provided, easier linkages, you know, as we're adding partners. And how we add more partners is that our current partners say, you know, I refer to this place all the time. Will you reach out to them? And then we do, and it usually goes well. It's free for all of our organizations to participate because the health department pays for it. So, you know, it's just been a very easy process. The ability to connect families to services become much easier. And this is the most important part, you know, reducing those barriers that people find, waiting on hold for a long time. When you're already in crisis and you're feeling stigma, you're worried about reaching out, and then you have to sit on hold for an hour just to be told maybe like there's a 6-month waiting list. Okay. We're eliminating some of those things on the front end where when we make the referral on behalf of our client, then that organization that receives the referral will proactively call that person and reach out. So it really cuts out a lot of barriers, makes the workflow more efficient, like we kind of talked about, and the partner communication, since it is a HIPAA compliant tool, heavily vetted, we can communicate quickly with personally identifying information if we need to, like a new number when we get a disconnected number, things like that. So it's really just also increasing partnerships and outreach efforts naturally kind of through this use of this tool. And at our annual meeting, our community standards say 5 business day initial response, and our average was actually only 2 days, which I thought was just amazing because referrals sometimes take the old way a lot longer. And one of our community partners early on just reached out just to give us some feedback. And they said they sent a referral through Iris for an adult today to AID, one of our awesome organizations, at 10:48 a.m. At 11:14, they received a message that they had accepted the referral and the individual was already scheduled for an intake appointment. So, you know, it doesn't always happen that fast, but I mean, that is not even an hour turnaround to the point where the client was referred to when they were enrolled in service. And again, not all communities do this, but we decided to adopt a cross-sector approach. And so our community members, you know, can end up going to like career services, and Jerry Huang over there can say like, oh, well, if you're looking for a new job, do you also need childcare? And he's done this. Do you also need childcare? Do you need clothes for your interview? Do you need these things? And then he can go into the system, even though he's a tech guy, he can go into the system and refer them to all these services they need using the convenient search filters. So these things are actually happening, and it's really awesome to see other providers that might not be social workers or case managers making these connections. And then there's a lot of transparency about capacity to serve in the moment, in the real time. Those local organizations are actually the ones updating their profile and indicating to the community what their actual capacity is. And again, it's HIPAA compliant, so we don't have to worry about our undocumented folks and other types of vulnerable folks. It's very vetted for HIPAA. And then, if you are on this call and you're a partner organization that isn't part of this system yet, it's so easy. We just provide you with a demo and information session via Zoom or in person, and then you fill out one piece of paperwork and you're ready to use the system. And there's like a 24-minute training video that you can give to all staff, or we can provide training. And even though the system is super intuitive and you really probably wouldn't even need it, but just for quality purposes, it's very, very easy. And then finally, the last thing that I just want to show you guys is from our last annual meeting, and we'll be updating this soon, is our referral map. It looks like a big mess, but what I do is I enter the data into this awesome data visualization tool called the Kumu map. And you can see all the organizations that are participating and who they're referring to and who they're receiving referrals from. And the ones with the largest dots are the largest recipients or senders of referrals. You see like our coordinated intake, you see our early learning partnerships, and we have a pediatrician that does a ton of work on this. All of our court services, our housing and utilities assistance, mental health, our FQHCs do a great job. But it just gives you access to serve your clients that much better, to actually wrap them in care and address all of their needs in one place. So that's it. And thank you for attending and listening, and you can reach out to me if you have any more questions or are interested in joining our IRIS system.
Thank you so much, Kim. That's really great. IRIS is a wonderful tool. So we're so glad that so many organizations are using it, and the numbers speak for themselves, right? That's really amazing how many referrals have been made. So we are going to move into the question and answer portion of the presentation now. So so far we have received one question. So I'm going to go ahead and ask this. Patrick did answer it in the chat, but we just want to open it up for anyone else for more conversation. What sources of funding are available for reducing social isolation? If anyone else has some more input on that.
So Stacy, I typed it in the chat, but
Oh,
the
yes.
Illinois Department on Aging and some of the Illinois area agencies on aging that receive federal funds that are dispersed have some opportunity for those types of funds. And social isolation has been high on their list of things they're concentrating on for the past couple of years.
That's great. Thanks, Lori.
Great. I'd love to see some of that funding, how that's how it's being distributed. And because I think that a lot of the work that IDOA does address social isolation, loneliness, but seeing definitely how that's laid out. I'll definitely look into it. But I know that that's something that we do as an institution, is we provide some institutional funding to support our social isolation initiatives, which is basically like when health systems or large organizations see the value in doing that and then provide some revenue towards it, towards supporting that. But I will say that a lot of times, a lot of people want to address social isolation and loneliness, but very few funders are willing to fund that work. And so oftentimes, even though we have a really robust social isolation plan of what we want to do to address social isolation and loneliness, we apply to funding and it's just oh, well, this foundation received so many applicants, and it's really hard to get funded. So to this day, I think I've submitted about 4 or 5 different grant applications. We haven't gotten any, which is really discouraging, but we're keeping on with it. I can say that much.
Well, hopefully that will change in the future. So for those residents who cannot afford mental health services, how can they be assisted? I'm not sure who could best answer that question.
Well, I think I'll jump in, Stacy. I think, using a tool like Iris is an excellent opportunity because when you go in, you can actually look at what services are provided and who's eligible. So as we continue to work on expanding the number of providers who are in Iris, we're expanding who we can get access to. But also, we do have a tremendous need for more support, especially for our safety net providers. So I did want to just really acknowledge and thank, I see State Representative Barbara Hernandez and Kane County Board members Anita Lewis and Dr. Monica Silva, who joined us, and all three of them I know have done tremendous work to increase resources around mental health. So a lot more work that we have to do at the community level, but specifically to Tina's question, I think Iris is a great place to start.
Great. If interested in helping others from a layman's perspective, where could individuals look to volunteer to address the issues in our communities? It's a great question.
Stacy, I think Lori from AID was wanting to say something. She had
Oh,
her hand
okay.
up.
On that one.
No, not on that one. So that's okay. You've answered most of the questions. The other thing I was going to say is that many townships and counties also have senior or social service funding, as well as some community mental health boards. I see Delilah, et cetera, that have funds for that could be given for social isolation as well. It was just going back to that. And then there are a plethora of mental health organizations in Kane that will serve people with a mental health diagnoses without a lot of money attached to it, right?
And I shared this Michael again, sorry to jump in, but I see Aaron Thrower from Dundee Township with their new 708 board. So yeah, lots of people working together to address this.
We have another one. Is there specific data for substance abuse statistics, mental health issues like suicide rates for King County cities, for example, Elgin, or is it just overall King County health data? Michael, you want to take that?
We do have more specific information, and we're actually, Kelly Howell is on the call today, our epidemiologist. We're working on putting together some updated reports that we can provide specifically to communities so that they have the most localized information that's available to help them with their programming. So over the next couple of months, there'll be a lot more specific information coming out.
Great. I don't know if, I don't think I've missed anything. Some are, this one was specifically for Dr. Happ. Since COVID, many organizations have moved to virtual classes. Do you see that as a good option to provide classes and address senior isolation, or is technology still a barrier for them?
Well, I think it's a little bit of both. Now that COVID restrictions have lifted some, there are many that prefer face-to-face services. But I can speak from my own client caseload that when those restrictions were lifted, each one of my clients who are aging said, this really works for us. This works very nicely, and are still remote. So, you know, I think it really depends on the individual. Classrooms also. I mean, you know, I prefer face-to-face, but again, even to this day, we still have remote learners. And I think we will from now going forward, honestly. So I'm glad we can accommodate both.
Yeah. And then just to follow up on the data information, so the Kane Health Counts website, which is kanehealthcounts.org, and that was placed in the chat, is our data website. So you can create dashboards and drill down in some cases to zip code level to find data on different indicators. So you're welcome to visit that website. And this presentation will actually be posted there as well with our contact information. So. And Lori does also say IAD always needs volunteers for our crisis line of the Fox Valley. I believe Patrick said that they're always looking for volunteers as well. Does anyone else want to say anything about volunteering?
Oh, I was just going to plug the MRC. Sorry, go ahead, Mickey.
This is Mickey Miller from Senior Services Associates, and we always can use volunteers for our transportation program and our friendly visiting program. We also place volunteers in many of the locations. We have sites that 55 and older can volunteer at throughout the county. So we're always willing to interview new potential volunteers.
That's great. And then Kate, I know you were going to mention our MRC program. Did you want to talk about that quickly?
Oh, sure, or you can too. I was just going to say the MRC is a great group of volunteers at the health department. That stands for the Medical Reserve Corps. But we actually have been in talks about trying to maybe proactively try to recruit some more people interested in working in mental health or interested in getting some training in mental health, or mental health workers who might want to join us so that we can expand some of the efforts into those areas. So that's just getting off the ground now, but another opportunity for the future.
Yeah, that's great. And then Patrick says that also if you have any folks that believe would benefit from the friendly call, that you can refer them to him, and he placed his email in the chat as well. Fox Valley Hands of Hope trains and engages volunteers to accompany and serve people who are living with a death loss. So that was shared by Jonathan Shively from Fox Valley Hands of Hope also. So lots of opportunities to volunteer and get involved here in King County. So excited about that. We are at time. So I just want to thank all of our presenters today. We will be sharing this presentation on the canehealthcounts.org website. So you can go back and watch that and get any of our contact information to follow up. So thanks so much for joining us today, and we look forward to seeing you again next year.